Okay, and in a fasting sample or even a non-fasting sample, there are some alarming figures, right? So if you find the levels are above these figures, urgent attention is needed, right? For an example, if the triglycerides are above 880, if LDL cholesterol is above 190, LDL above 500, and we are not doing this much. This is both for adults and children, so I'm not going to go through lipoprotein, apolipoproteins here. So considering these factors, if the levels of the patients are above these cut points, there has to be urgent investigation into them. Right. So how do we perform the fasting lipid profile in children? What is the standard duration of fasting? Now, a child has to be on a normal diet for 4 to 6 weeks, and then the overnight fast of minimum 8 hours. So 8 hours is internationally accepted as the adequate duration of fasting. But the preferable level is 12 to 14, but we need to make sure at least 8 hours fast is there. The problem with fasting sample in our societies, although they say the child has been fasting, it's not very reliable. So most of the time, it is a non-fasting sample. So we need to keep in mind, we should not be interpreting triglycerides on a non-fasting sample because it is highly affected by the diet. Okay. Right. And also, I think I missed in one slide that the LDL estimation in a lipid profile is a derived factor by a formula which takes triglycerides into account. So that is why we can't reliably interpret LDL in a non-fasting sample because it is affected by the triglycerides. Okay, now in our targeted screening, I talked about the risk factors, the high and the moderate risk factors. Where there are risk factors, we need to do targeted screen. So these are the risk factors laid down by the international guidelines, like current cigarette smoking, especially in adolescent population, and very high BMI in the child, high blood pressure needing treatment, diabetes type 1 or 2, Kawasaki disease with persistent aneurysms, organ transplant, and chronic renal disease. So these are considered as high risk factors if they are present, to go for targeted screening between very early in life. And the moderate risk factors include the obese category, high blood pressure that does not require treatment, that is mild hypertension, low HDL levels, Kawasaki disease with regressed aneurysms, SLE and JIA, HIV, nephrotic syndrome. So these are, maybe these things are changing from time to time, but these are what that are laid down at the moment. So having talked about the etiology and how we identify these children, now I'm going to talk about how we are going to manage these children with abnormal lipid levels. So first I will talk about the management of adiposity related dyslipidemia, which is the commonest we find in our practice. So a child who is overweight and is more than 10 years of age and has the atherogenic lipid pattern, and there is no family history or any other risk factor, no high or moderate risk factors. So these children usually undergo therapeutic lifestyle interventions only, and they are followed up with fasting lipid profiles annually. So statins or omega-3 fatty acids, none is required for adiposity related dyslipidemia initially. Right. So what are these therapeutic lifestyle interventions? What we aim at is weight reduction or weight maintenance, because just by weight reduction the lipid profiles improve. So the weight goals are Below 12 years of age, we aim at just weight maintenance without any weight loss. And above 12 years, a 10% weight loss over 6 months. So generally these lifestyle modification programs are prescribed for 6 months. And then we hope that the changed lifestyle will continue for the rest of the life of the child to maintain a healthy BMI. So this lifestyle modification includes 3 main components: introducing a low-calorie diet, increase physical activity, and behavior therapy. Right. So there are no strict diet plans or therapeutic meals for these children. It's just introducing healthy food, making the children and the family aware of the healthy food consumption, and also giving them an idea how they can look at the calorie count of various food items. So, they have the liberty to choose the healthy food items for the child. So, by that we aim at putting the child on a low-fat, low-carbohydrate diet with reduced portion sizes. Most obese children consume very high portion sizes, sometimes even more than what their parents eat. And also no added sugar and complete avoidance of sweetened beverages. Right? So these are the main aims of introducing a healthy diet for these children. And just to make you aware, there are therapeutic diets as well, where they are prescribed by medical nutritionists under certain circumstances, especially when there is very high triglyceride levels and very low HDL-C levels. So this is an example of a child 1 diet, which is called, it's obscured here by this box here, but it's a therapeutic diet which is prescribed for children with severe hypertriglyceridemia. So like this child 1 diet, there are stepping up diets, child 2 diets. They may not be very palatable, but these children are put on these diets for a limited period of time to improve their lipid profiles to prevent pancreatitis basically. And also these children are the ones who have the hereditary hyperlipidemias. So they are at high risk of cardiovascular events even during the first decade of life. So that is why they are prescribed with these special diets. Right. And the physical activity guidelines recommendations are for children between 3 to 5 years. They should be physically activity all day long. And from 6 to 17 years, at least 60 minutes of moderate to vigorous physical activity per day, and also restricting the screen time, television, video games, and non-scholastic internet use, which is happening these days, to 1 hour or less. So these are the physical activity guidelines that we introduce to these patients with adiposity related dyslipidemia. And also these activity pyramids are also used to educate the families. This is a useful guide for both parents, children, and also for health professionals. So the child and the parents have to go through this and select activities from each levels. Right? What can they do every day? What should be done every 3 days per week? And what should not be done? Right? So this is a comprehensive guide for the parents and children to choose their physical activity. And also we had to make them aware that physical activity is important not only for improvement of their lipid profiles, but there are so many benefits of being physically active, like improving their bone health, muscle health, their concentrating ability, the sleep quality. So there are so many advantages of physical activity. Right. So behavior therapy, in short, it's basically aimed at motivating the child. So in obesity clinic, a lot of time is spent to motivate these children to reach their goals. Even the goal setting is done collaborating with the child. It's very visible, but I just wanted to show you that there are algorithms how to follow when we manage patients with abnormal lipid levels, interpreting together with BMI to consider using the statins and omega-3 fatty acids, but I will go through these in separate slides. Now, statin therapy is recommended only about 10 years generally. So, all the statins which are available in the market can be used in children as well. And we need to do baseline liver functions before starting on statins. And initially, it started at a low dose and increased in 6 to 12 week increments while monitoring the liver functions and lipid profiles every 3 months. And the lifestyle modifications have to be continued. So remember that we start statins only after 6 months lifestyle modification program, right? We don't just start statins without lifestyle modifications. So the goals of statin therapy are, if we use LDL as the tool for monitoring, LDL levels below 130 milligrams per deciliter, but less than 100 in high-risk children. If there are premature deaths in the family, or there are other high-risk factors, we have to maintain a lower level. And if we use non-HDL cholesterol as the monitoring tool, it has to be maintained below 145. But however, at the moment, the international guidelines recommend LDL monitoring rather than non-HDL, because there are certain controversies, right? So there are meta-analysis of several randomized controlled trials done on statin use in children for their response as well as the safety profile. So all of these studies have shown response rate of 20 to 50% within 6 months to 1 year period of using statins, and none of them have reported any significant side effects with reference to abnormal liver functions or muscle enzymes or any effect on puberty or growth in children. But however, the limitation is none of the studies have gone beyond 3 years. So we are still waiting to assimilate data on long-term studies. So a lot of studies have been done on statin safety in children where they have reported there has been no difference between the side effects between the statins and the placebos. So it's quite safe to use in children. Right. So is non-HDL cholesterol a better predictor? Now it is recognized. There are a lot of evidence brought up over the past few years saying that non-HDL cholesterol is a better predictor of atherosclerotic cardiovascular disease. But however, for monitoring purposes, still LDL is recognized as the gold standard, but this is also recommended in certain guidelines. So probably we can keep looking at both figures because it's very easy to calculate the non-HDL cholesterol levels in a lipid profile. Right. So this is regarding the use of non-HDL cholesterol. So these two studies give different opinions. This study, which was published in an American journal, says it's a very good predictor of cardiovascular disease and recommends for monitoring. But in the other study says there is a controversy because non-HDL cholesterol does not represent the entire level of LDL in its in a lipid profile. Therefore, it's still questionable. Right. So, if a child has high risk lipoprotein levels in the lipid profile, but the child is less than 10 years, what are we to do? So, the usual statins that are available in the market are not recommended below 10 years of age. So, but there are two statins, pravastatin and pitavastatin, which have been used in children, have shown to be safe. But however, in our setup, we only try with lifestyle modifications. Apart from statin, we can use omega-3 fatty acids on these children. So while using statins, we have to continue the non-statin strategies as well to reduce their overall mortality risk, like preventing them getting into the habit of cigarette smoking, maintaining appropriate nutrition and the BMI, physical activity goals, and all these things, stress management, are all important in the follow-up of these patients. Right. So now I'm coming on to talk about severe hypertriglyceridemia. So it is either hereditary or it could be lifestyle related. So both conditions we come across in our practice. If the triglyceride levels are very high, in small children, it is usually genetic, right? So they present with lipemic serum, and sometimes we find that there is a strong family history of cardiovascular disease. So those children belong to the category of severe hypertriglyceridemia, and you already know that there is a very high risk of pancreatitis when the levels are above 800. And treatment is recommended when levels are above 500 milligrams per deciliter. These levels close to 500 sometimes we see in overweight and obese children with metabolic syndrome as well. And what can we use to treat these children? So what is recommended for pediatric hypertriglyceridemia is omega-3 fatty acids, but in high doses. So they have to receive about 3 grams, that is 3000 milligrams per day. So the general strength of one capsule is about 1000 milligrams. So 3 of it to reduce significantly the levels of triglycerides, you need a very high dose. Also we can use fibrates and niacin, but they are not very well tolerated. Even omega-3 fatty acids, they can give some gastrointestinal side effects, but they are recommended if the triglyceride levels are very high. So omega-3 fatty acids again have shown reliable results in multiple clinical trials, but in high doses. The low doses have not shown any benefit. Right. Okay. So looking at our children in Sri Lanka, so what should we be doing? Right. So first we need to understand the prevalence and the pattern of dyslipidemia in our children. Right. And probably we start targeted screening to begin with, and then move forward for universal screening. And most importantly, we have to take measures to prevent childhood obesity. So I'm not going to talk about childhood obesity here because it's out of the scope of this lecture, right? So the BMI trends of Sri Lankan children is alarmingly going up over the past decade. So these are the figures from Family Health Bureau 2017. This is looking at children between 10 to 15 years. And we have done some prevalence studies in various districts. So very high overweight prevalence is found in Colombo compared to Kandy. So this Kandy school survey was done over the past 2 years. So again, this involved 14 schools in Kandy, and we found the prevalence of overweight among 14.6% of children, obesity among 6.8%, and metabolic syndrome was prevalent in 11.7% of them. Right? So metabolic syndrome, compared to international figures, it's about 18% in Western countries. So it's slightly less, but I think we are going there. Okay, so these are data, the dyslipidemia pattern in children we found in children in the Kandy city limits. Actually, these red and green areas represent borderline and abnormal levels. You can see actually nearly 50% of children with overweight and obesity have dyslipidemia. So we are actually facing an alarming situation, especially related to adiposity. Right? Okay, so finally, Now in my lecture I have gone through the relevance of dyslipidemia to pediatricians, and who are the children at risk, what are the various types of dyslipidemia we see among child population, how can we identify them and screen them and treat them, right? So my take-home message is that we need to initiate some sort of screening in our children, probably starting with children with risk factors. We may go by the prevailing international guidelines, which says targeted screening in children with history of these risk factors starting at 3 years of age, and then if that's normal at 9 to 11 years, and then at 18 years of age, and we should aim at universal screening later on. And also adolescents have to be screened after 16 years of age every 5 years to identify these risk factors early in life and prevent adulthood cardiac morbidity and mortality. So anyway, the bottom line is that healthy lifestyle is the key to cardiovascular health, and as doctors and parents, it's our duty to inculcate healthy lifestyle in our young generations. So thank you for your patient listening.